Good afternoon or morning or wherever you're listening to this. My name is Sandro Cinti. I'm an infectious disease physician at the University of Michigan and the Ann Arbor VA. And I'm going to talk to you today about approaches to dealing with patients who have HCV co-infection with HIV. Just to mention, I have no conflicts of interest and no financial disclosures. The objectives of my talk are the following, three main objectives. The first is to talk about the epidemiology, the natural history of HCV and HIV co-infection. The second is to discuss the diagnosis and evaluation of co-infected patients who have HIV hepatitis C. And finally, to talk about treatment of co-infected patients, because there are currently some new therapies that have come along. To start with, there are currently about 10 million people who are co-infected with HIV and hepatitis C in the world. There are 40 million HIV-infected patients around the world and many more, 175 million, who are hepatitis C infected. They intersect at about 10 million people who have both. In the United States, the epidemiology dictates that about 30% of HIV-positive patients are co-infected with HCV. 73% of these who are HIV-HCV co-infected are IV drug users. The routes of transmission include percutaneous transmission, which is needle stick or direct needle exposure in IV drug use. This is the highest, of course, in IV drug users and hemophiliacs, although with new testing guidelines, very few hemophiliacs have been infected recently. IVDUs tend to get hepatitis C before they get HIV, so they're often infected first with hepatitis C. Sexual transmission does occur. It is males who have sex with males. About 4 to 8% of HIV-positive patients who are MSM, or males who have sex with males, have HCV also. Usually, unlike IVDUs, their HIV is acquired before their hepatitis C. In heterosexuals, there's a very low infectivity, so sexual transmission of hepatitis C occurs much less frequently among the heterosexual population. Other modes of transmission, I already mentioned needle sticks in healthcare workers. Perinatal transmission is very rare, but it tends to a higher incidence in HIV co-infected patients. Those who have both HIV and hepatitis C have a higher rate of perinatal transmission. The prevalence of chronic hepatitis C in HIV patients is, as I said, about 30% to 35% in this country. If I look at my patients in my clinic at the VA, about 30 to 35% of my HIV patients also have hepatitis C. A smaller number, about 2 to 3%, have hepatitis B as well as HIV. And triple-infected patients are quite rare and represent probably less than 1% of the population of patients who have HIV. The pathogenesis of liver disease is interesting. In HIV hepatitis C co-infected patients, they tend to progress more quickly to cirrhosis and end-stage liver disease. It's not clear why this is. It does seem to appear that patients who are co-infected have higher hepatitis C viral loads. And again, it's not clear why that occurs. Now, having higher viral loads of hepatitis C doesn't necessarily lead to more cirrhosis and end-stage liver disease, but it may make HCV, hepatitis C, more difficult to treat. So getting HIV under control is very important in this patient population. HIV-HCV co-infected patients are more likely to get hepatocellular carcinoma over a shorter period of time, and studies have shown this occurs in 26 years in the co-infected patients versus 34 years in people who have HCV alone. HIV-positive patients are also living longer, and so what we're seeing is an increased incidence of cirrhosis, end-stage liver disease, and also hepatocellular carcinoma. Remember, patients with HIV are almost all on treatment now, and these treatments have effects on their liver. And if they are co-infected with hepatitis C, there's an additive effect of the hepatitis C effect on their liver and the effect of their antiretroviral medications. HIV therapy does decrease progression of hepatitis C, so it's very important that all patients with HIV are on highly active antiretroviral therapies. Sometimes we call it HAART, H-A-A-R-T. But remember also that HAART can cause liver toxicity, and so it sometimes is difficult to determine why a patient's liver enzymes are going up if they're co-infected. Hepatitis C does not worsen the progression of HIV in general, so we have not worried about that as much. The mean progression to cirrhosis among HIV patients is about 25 years, and this is threefold faster in HIV-positive patients than it is in people who are hepatitis C infected alone. There are many studies that show the risk of cirrhosis and end-stage liver disease and the risk of progression, or the relative risk of cirrhosis in either of these, is anywhere from 2 to 4 times higher in patients who are co-infected of getting cirrhosis and up to 7 times higher of getting end-stage liver disease. So this is a real problem, especially as our patients who are co-infected, our HIV patients, are living longer. We didn't see this 10 years ago or 15 years ago because we didn't have the HIV therapy that prolonged the survival in our HIV population. So it's just now that we're starting to see the effects of being co-infected with both. The diagnosis of hepatitis C is the next thing I'm going to talk about. The main diagnostic test is the ELISA for hepatitis C. It's 99% sensitive and specific. Now, false negatives can occur, and particularly in patients with HIV who have very low CD4 counts. So if their immune system is down and they have AIDS, acquired immune deficiency syndrome, which occurs at a CD4 count of less than 200, you might get a false negative. Rapid tests are being developed, but they're not universally available at this time. So the next possible test to use, and should be used in HIV patients, is a quantitative hepatitis C RNA test, particularly if you are trying to assess for viremia. HIV-infected patients tended to have a higher viremia, and this also helps with the diagnosis because if a patient has a false negative ELISA, the quantitative HCV RNA is likely to be positive and very high. Viremia, again, is higher in patients with HIV co-infection. LFTs are really insensitive in diagnosing hepatitis C infection in HIV patients, particularly because, as I said, most of these patients are on highly active antiretroviral therapy, and they end up having some abnormalities of their liver enzymes at times during their disease. Testing should also occur for hepatitis B, and if patients have hepatitis B, for hepatitis D, sometimes called delta hepatitis, and also for hepatitis A. Further evaluation of patients includes a history and physical exam. History for substance abuse, psych disorders, medications, and pregnancy is very important when you're thinking of treating for either HIV or hepatitis C. Looking for stigmata of chronic disease, including spider hemangiomas or angiomata. Also, hepatosplenomegaly and jaundice are important to look for. The labs that need to be obtained when you're working up and further evaluation of hepatitis C once a patient has an initially positive test would include the quantitative RNA test, the hepatitis C genotype, which is very important, and we'll talk about that in treatment. Also, liver function test, AST and ALT. You should see a higher ALT than AST generally, and if you see the opposite, you have to consider that maybe this is due to alcoholic hepatitis. Bilirubin and alk-phos are also important to get. You should get a CBC with different platelets, basic thyroid panel, albumin, PT, and patients who are hepatitis C infected. And if you're thinking about treating those patients, they should get a pregnancy test if they're female. CD4 count and viral load are also very important. You want to make sure that patients' viral loads are suppressed on highly active antiretroviral therapy. And if they're not suppressed, then you should speak with the infectious disease physician about suppressing the HIV viral load or changing medications. Or you should assess the patient's ability to be able to take medications, because often when the viral load is positive, patients with HIV are non-adherent to therapy, and that's the reason that they're still having a viral load. Hepatocellular carcinoma evaluation should also occur in cirrhosis. In terms of staging liver disease, all patients should be assessed for cirrhosis. I'm not going to talk much about cirrhosis here because I'm not an expert in that, and I think you've had other talks about that. But patients who do have cirrhosis should be screened for hepatocellular carcinoma, as I mentioned above, with ultrasound or CT scan and alpha-fetoproteins. We do that very commonly in our HIV clinic. Also, they should be screened for esophageal varices, and sometimes that includes getting an EGD. It's not clear completely when liver biopsy should be attained. However, there are certain reasons why liver biopsy should be obtained. One, if patients have minimal disease, sometimes you can avoid treatment or wait on treatment of hepatitis C and work on treatment of HIV first. The biopsy will help you with the rate of fibrosis. It will help you determine whether the patient has cirrhosis and may require treatment changes. Why not do it? It's a fairly insensitive test, and there is sampling error. a negative test doesn't necessarily mean that you won't treat a patient if other testing is consistent with liver disease. Recommendations in HIV patients are really to discuss with the patient, but to do a biopsy in HIV patients who have a genotype 1 hepatitis C virus, because those are the most difficult to treat, and patients with very high HCV viremia, greater than 400,000 international units per ml. Those two tests are very commonly used as a reason to get a liver biopsy. However, you should discuss liver biopsy of HIV, HCV co-infected patients, both with the ID physician and the GI doctor, to determine if it's the best thing to do. Let's move a little bit towards treatment and predictors of response to therapy. Before therapy, what you need to look at is the genotype. Patients with HIV or even without HIV who have a genotype 2-3 do much better when treating their hepatitis C than if they have a genotype 1 or 4. Now, as many of you know, the most common genotype in this country for people infected with hepatitis C is genotype 1. Probably 80% of patients will have genotype 1, and that's the same for our HIV population. But if you look at the differences in success, and success in treatment of hepatitis C is a sustained virological response after 12 weeks. And genotype 2 to 3 have a 40 to 70% sustained virological response versus 17 to 30% sustained virological response in HIV, HCV co-infected patients. Because of this finding and because of the lack of success, we have not treated many of our HIV, HCV co-infected patients for HCV because of how difficult the treatments are, and response rates of 17 to 30% really don't convince a patient to take that therapy. Other predictors of response include a baseline hepatitis C viral load that's less than 400,000. There's a much better response rate. Things that bode poorly include insulin resistance, immunosuppression, advanced fibrosis, and high BMI. All are poor predictors of response to therapy. It doesn't mean you shouldn't treat those patients. It just means that the response is not as good. There are also some genetic factors, and there are some polymorphisms associated with a favorable outcome, and some people are using the IL-28B genotyping system to check that. However, that is not ubiquitous, and it's not something we do at the University of Michigan. Predictors of response during therapy: if somebody's undetectable in their hepatitis C viral load at 4 weeks, it's a very powerful predictor of long-term sustained virologic response. Also, an early virologic response at 12 weeks with either an undetectable virus or a 2-log reduction is really indicative of potential success over the long run. Let's move now to treatment. The treatment goals are the following. The primary goal is to achieve a sustained virologic response, SVR, which is defined as an undetectable hepatitis C virus RNA 24 weeks after the end of treatment. It's called SVR 24. Secondary goals are improved fibrosis, and you could only tell that by doing another biopsy, reduction in morbidity and mortality, reduction of progression to hepatocellular carcinoma, and a reduced risk of toxicity from HIV therapy. And that's a very important one because, as I said, highly active antiretroviral therapy is very difficult on the liver, and anything we can do to improve the liver's ability to handle these medications will be beneficial to the patient. So who are the candidates for treatment? No treatment should be given in people who have minimal hepatitis C virus disease. So that would be somebody who has very minimal findings on labs or on biopsy. It's most pressing in patients with bridging fibrosis or cirrhosis. So again, this may make biopsy an important thing to get in patients who have other clinical indicators that they have advancing liver disease. Treatment is contraindicated in uncompensated cirrhosis because you're not going to change that very much by giving treatment. In pregnancy, so if a woman is pregnant, you should wait till after she delivers to give her treatment. Uncontrolled depression, because interferon really causes problems with depression and exacerbates those. Unstable cardiac or pulmonary conditions. So until those things are controlled, the patient should not be treated for hepatitis C because the treatment course is long and grueling and there are a lot of side effects, as we'll talk about. So, should you start treatment before or after treating HIV? And the answer is most of us are treating HIV right up front in our HIV-positive patients, so you almost can't avoid treating a patient who has HIV for the hepatitis C while they're on medications. If a patient presents with both, Sometimes we will hold off if the patient has a CD4 count of greater than 500. We will hold off treating with highly active antiretroviral therapy in preference to treating the hepatitis C. However, I will say that because of recent guidelines in the past 2 years for treating HIV, almost all patients with HIV, even those with CD4 counts greater than 500, are currently on antiretroviral medications. If you're starting after HIV treatment, you should wait 6 weeks until the patient is tolerating highly active antiretroviral therapy. So the treatments are the following. There's pegylated interferon and ribavirin. Initially, it was just interferon. In the last 10 years or so, we've been able to use both. And the pegylated interferon increases the half-life of interferon, has really increased the success rate. The interferon is given sub-Q once a week, but it has a lot of side effects, including fatigue, flu-like symptoms, weight loss, and depression, and all those can be already happening in people who are HIV co-infected. Ribavirin is weight-based dosing, and it should be given at 13 milligrams per kilogram divided in 2 doses. Side effects are also considerable and can include diarrhea, fatigue, and the real cytopenia that's concerning is anemia. Patients can get very anemic, get very fatigued, and sometimes you're chasing your tail treating their anemia or following that. The recommendation is only to use pegylated interferon and ribavirin as dual therapy in genotypes 2 and 3. If they're genotype 1, we're going to add a third drug, which I'll talk about in a moment. The duration of treatment for this patient would be 48 weeks. Outcomes in HCV HIV dually infected patients with just 2 drug therapy, pegylated interferon and ribavirin, for genotype 1, I told you, have been very disappointing at only 17 to 30%. Better for genotypes 2 or 3 at 50 to 60% with a sustained virologic response. Let's move now to the more involved treatment, which includes a new drug class in hepatitis C, which are called protease inhibitors. Now, we use protease inhibitors in treating our HIV patients, so we are very aware and facile with using that in the infectious disease community. However, these drugs just make it more difficult to monitor patients who have hepatitis C and HIV if we're using them to treat. The 2 drugs are called boceprevir and telaprevir. Telaprevir is given at 750 milligrams or boceprevir at 800 milligrams, and it's given at an unusual dosing schedule every 7 to 9 hours. Both have many drug interactions, particularly with HIV PIs. What I recommend for all you out there is, 1, you should be always monitoring patients when you give them new meds who are on HIV PIs, but now they might be on hepatitis C PIs also, so you really have to be careful of the medications you give them. You are likely not going to be monitoring their HIV medications or their hepatitis C medications, but you may be giving them other medications that interact. Some very clear concerns would be with dilantin or Coumadin or digoxin. You should always look and make sure that there is no drug interaction or if there's another agent you can use. Duration of therapy, again, is 48 weeks. You give telaprevir for 12 weeks, and then you add pegylated interferon and ribavirin for a total of 48 weeks. With the other drug, boceprevir, you start 4 weeks of pegylated interferon and ribavirin, and then you go with 3 drugs, pegylated interferon, ribavirin, and boceprevir, for another 44 weeks for a total of 48 weeks. The efficacy rates have been much better, and they're now up to 60 to 70% for genotype 1 in initial studies. Now, these are very new studies. We are not yet using this ubiquitously in our HIV, hepatitis C infected patients, but we are seriously thinking about how we would treat those patients, and we're starting to enroll our patients in some treatment trials. Monitoring the hepatitis C patient who's HIV infected and is on therapy for hepatitis C and on therapy for HIV, you really have to monitor for adverse events, which include anemia, nausea, weight loss, and psychiatric issues. Labs have to be monitored very frequently, probably every month for a while. CBC, renal function, HIV parameters. Certainly, if a woman pregnancy test should be retested. Response to hepatitis C therapy should be assessed at 4 weeks, 8 weeks, 12 weeks, 24 weeks. And then full viral suppression at 12 weeks is usually a great sign that they're going to be complete responders. If the patients have not had a 2-log reduction at 12 weeks, it's very likely that they will end up being non-responders. And so if you see that, we're often stopping the medications at that time in these patients. The take-home message is the following, I think. that HCV progresses more quickly in HIV patients, and therefore it's very important to try and get a hold of this disease. And now that we have a medication regimen that clears this disease in 60 to 70% of HCV co-infected patients, I think we may be treating many more of these. The addition of hepatitis C protease inhibitors, boceprevir and telaprevir, to pegylated interferon and ribavirin has greatly improved the response, and so we are looking forward to trying to eradicate hepatitis C in some of our HIV population. The 3-drug regimen for hepatitis C, in addition to the 3-drug therapy for HIV, makes managing these patients very complicated, and you really need to coordinate any approach with ID and GI involved, as well as those of you who are primary care physician of those patients. Thank you very much for your time.